your patients know what presbyopia is?
There are people who are afraid of the press.
Have you talked to your patients about multifocal contact lenses?
I've heard the bifocal, but not multifocal.
Exactly, not multifocal.
Do you need help with your multifocal strategy? Learn more at the conclusion of this episode.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. Welcome back to part 2 of my interview with Dr. Frank Contacessa. In this segment, Dr. Contacessa will delve into his favorite diagnostic blood tests and share his recommendations for living a longer, healthier life. If you're new here and you enjoy our interviews, press like, subscribe, share, and hit the bell. Also, we welcome your comments. Don't forget to check out our full-length documentary, Open Your Eyes, available on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube Movies and Shows. You know, we talked a little bit about fasting, intermittent fasting, and Jason Fung was in my movie. He was like the king of fasting. And I've heard people talk about fasting. Don't eat until 4 o'clock in the afternoon. But to me, if you do it that way, it's the sumo wrestler diet. You eat and then you go to sleep. You're famished. I find that if you're going to do intermittent fasting, now you disagree with me if you do, that the best way to do it is eat a big breakfast, eat a pretty big lunch, eat a dinner around 4 or 5 o'clock, and then don't eat the rest of the night. And I think you'll do a lot better that way. But what's your opinion on that?
I think it's really different for everybody. I think I mentioned before, I kind of do a modified version of that. And again, I kind of evolved into that because traditionally I've always done my workout in the morning. And then I'm not hungry right after I work out. So I was not eating breakfast until 10:30, 11 o'clock anyway, because I just wasn't hungry. And I'm a big believer in if you're not hungry, then don't eat. And there are people, a lot of people who aren't hungry in the morning. And, this idea of, well, breakfast is the most important meal of the day. Well, that was created by the breakfast industry. Like, that's not necessarily true. Now, if somebody is hungry in the morning and you want to consume a larger meal in the morning, and then have a modest lunch and then a lighter dinner, and that works for you, great. I'm not hungry at all in the morning, and I eat a modest lunch, and then I eat a normal sized dinner, at 6:30, 7 o'clock, and then I don't have anything until the next day at noon. So that works for me, and this goes back to that idea of that medicine is personalized, and there is no one size fits all. So for somebody who's just not hungry in the morning, then you shouldn't eat in the morning. Well, if you're not hungry, don't eat. Forcing yourself to eat, again, that's from the food industry. So I do like intermittent fasting. It's one of the few plans that really has good data supporting it, and it's got a really good biochemical reason that it works. That the philosophy behind it is kind of interesting. So I don't want to get too biochemical, but the short version is it helps to resensitize the cells and the target tissues to insulin. Now, a lot of people have no idea. They've heard of insulin. They know it has to do with sugar and diabetes, but they really don't know how it works. So I'll give like a 30-second explanation. So let's take a normal person, a normal non-diabetic person. You eat a meal, your stomach and your gastrointestinal system starts to absorb those nutrients. As you absorb the nutrients, your blood sugar goes up. So normal fasting blood sugar might be 80 or 90 or 100. You go up to 130, 140. Now your pancreas senses this. The sugar goes up, your pancreas says, okay, you just had a meal. Let's send out some insulin. Insulin is a hormone. A hormone is a chemical messenger. It allows one part of the body to talk to another part of the body, right? And the message is insulin says, take the sugar out of the blood and either burn it for fuel or store it for later. And it's talking to tissues like our muscles and our fat cells, our adipose tissues, our liver, things like that, our brain, any cells that are going to use the sugar. The glucose is the fuel of our body. It's the gasoline of our body. So the message is take the sugar out of the blood, either burn it now or store it for later. Sugar comes back down. When people eat too much, if they're overweight, if they're grazing all day on food, the tissues become insensitive to the insulin. They stop listening. They're not listening to the message anymore. It's almost like walking into a room with a smell, right? You walk, whether it's a good or a bad smell, you got a strong smell in the room. After 10 minutes, you don't smell the smell anymore, right? If you walk out of the room, you come back in the room, you smell it again. When you're in the room, the receptors get worn out, they get tired, they get insensitive to the smell. So intermittent fasting is like walking out of the room for a little while. It allows the insulin levels to fall. It allows those tissues to resensitize to the insulin so that the insulin works better, it works more efficiently. So that was a long answer to your question. Yes, I like intermittent fasting. I think it's modifiable. You don't have to follow the strict plan of this many hours, eat at this time. I don't think it has to be that, but I think people should get away from the constant grazing and eating that way. So overall, I do endorse intermittent fasting.
It's funny because that was a way they recommended diabetics to eat a number of years ago. Every 2 hours, they should eat something. If you could just comment on that.
Some diabetics do need to do that. Now, if you have a type 2 diabetic who's become very insulin resistant, their blood sugar levels can fluctuate more rapidly, and it's harder to control them. So some people should eat like that. These are broad generalizations, but there are some diabetics who need to eat more frequently, and it depends on whether they're on insulin or not, and what types of medications that they take. Because some medications that we use to treat diabetes can cause hypoglycemia. In other words, they can drive the sugar too low. So that's what you're trying to avoid in certain people who take those types of medications. You have to be a little bit careful.
But the average person who is not diabetic or pre-diabetic, you would recommend they don't graze all day.
Correct. That's correct.
So I want to ask you about juicing or blending. What do you think?
So I don't know, about a year ago, I kind of got into the smoothie shakes, and I think I don't really use them as meal replacements. I use them sort of as a supplement. After I work out, and you have to use really good organic, clean ingredients, and you have to be careful about what you put into them. Be really careful on protein powders. You have to have a high quality protein. Some of the things that are on the market, they're adulterated and they're not really good products. I do like these things because it's a quick and easy way to get more fruits and vegetables into your diet. Because unless you can eat everything raw, cooking vegetables takes time. You have to be creative. You have to come up with new recipes, and it can take time. But if you can put everything into a drink and get 4 or 5, 6 servings of fruits and vegetables in a drink that you have in 10 minutes, it's just a great way to supplement what people might not be getting enough of otherwise. Because listen, the bottom line is eating healthy is difficult and it's expensive. To buy high quality foods and to make them appealing and to make them enjoyable and not get bored, it's expensive and it takes time and effort. So the people who are the healthy, they do meal prepper, they do meal prepping. On Sunday night, they might cook meals for the week so that they can go to work and have their meals set. But it's difficult to do. But I do like the blending. I think, and you have to be careful. Some juicers, especially remember the old juice man, the guy with the eyebrows. You remember that old machine? That machine wasn't great because it actually took a lot of the fiber and the pulp out. And whereas a blender, a Ninja or a blender will keep that fiber in, and you want that fiber because because some of these shakes have a lot of sugar. If you put berries and you put a lot of fruit into your shake, it's got a lot of sugar. Yes, it's fructose, it's natural sugar, it's better than table sugar, but it's still a lot of sugar. But if you take that with a proper balance of protein and fiber, then your body processes that a lot better.
I think it's important that when people use the protein, it's undenatured or non-denatured protein. Are there any brands that you like? I mean, as far as protein that you would recommend?
I don't personally use a protein powder. I've looked into a couple of them. I haven't found one that didn't have some kind of a drawback, whether it's the flavorings that they use or the ingredients that they use. My protein source for the shakes is Greek yogurt, is plain or vanilla Greek yogurt, organic yogurt, and Greek yogurt is loaded with protein. So that's one of the ways that I get extra protein into there.
And I also and tell me if you agree with this. I think it's very important when you're doing a smoothie that it's organic, because you're using such a high concentration of different vegetables and fruits that you're going to get a big concentration of poisons if it's not organic.
I think everything should, especially produce, needs to be organic these days. And again, the more you research and the more you learn about the agricultural industry and what non-organic products have, you wouldn't want to eat them or consume them at all. So yes, I agree with you 100%. It's worth spending the money. You can go to Costco, and I'm a big Costco fan, and they're carrying more and more organic products these days. You can go and buy the ingredients for these smoothies, and they're all organic. You can buy organic blueberries frozen. You can buy organic mango. You can buy organic berries, all ready to go. Dump right into your blender, and it's just a quick and easy way to do it. And they have better prices. So spend the money on organic; it's worth it.
Talk about labs that you recommend. What are some labs that you think are absolutely essential that people have? They come into your office, they're interested in anti-aging. What labs are you recommending?
So if you go above and beyond, so most people, if they go to a regular doctor and you have a physical, you have your yearly wellness exam, they're going to do a CBC, which is blood counts. They're going to do a metabolic panel, which is liver functions, kidney functions, electrolytes. They'll probably do a standard lipid panel, maybe a thyroid and a urinalysis, which are great. And those things should be done. In my practice, I'm, as I mentioned, I'm sort of a concierge physician, and I work with a company called MDVIP. And one of the things that we offer as part of the plan is a panel from the Cleveland Heart Lab, which goes above and beyond the standard labs that you would get with your yearly physical, with your Medicare exam. And a couple of the tests that I'm finding are more and more valuable for predicting heart disease and other risks. So you mentioned earlier C-reactive protein. So there are some inflammatory markers, and we're really finding that a lot of illness and disease is a function of inflammation in our bodies. So inflammation is bad. And getting back to diet, many people, the diet is pro-inflammatory. The diet, what you eat, causes inflammation. But checking these inflammatory markers, so C-reactive protein, and there's a couple of other markers that when you look at these, they can really help you to decide, is somebody at a higher risk or are they not? Another test I really like is lipid fractionation, so lipoprotein fractionation. So this is breaking down, everybody knows the HDL, the LDL, triglycerides, those kind of things. If you break those down into component parts, there are some other measures that we can use. And it's really interesting because before I started to use these more detailed tests, you could look at somebody's blood work at their standard lipid panel and say, oh, your cholesterol's high, your LDL, the bad cholesterol is too high. Maybe you should take a statin, like Lipitor. Or there are people who I would look at their panel and say, you don't need it. But now that I have that and this fractionation, which is sort of a deeper dive on the specific types of particles that make up LDL and HDL and these lipids, to say, wait a second, your balance of these things is actually fairly healthy. So even though your cholesterol is a little high and your LDL is a little bit high, I don't think you need a statin, because now that I look at your more detailed labs, I don't see a picture here that increases your risk for heart disease, or vice versa, where their numbers were pretty good on the standard lipid panel, but then I look at their fractionation and I say, wait a second, your LDL particle count is really, really high, and it's the small ones which are the bad ones. So maybe we should consider a medication for you. So these are some things that your insurance may not pay for, because they're only the standard. Every test that needs to have a diagnosis code, and they will pay for certain tests with certain diagnosis codes. So you may have to pay out of pocket for some of these things, but you're talking hundreds of dollars, not thousands of dollars, and it might be worth it.
So when you do the NMR, it's basically that we're looking at small particle LDL, and that's high risk for cardiovascular disease, because it's not so much the cholesterol, but the lipoproteins that could get caught into the arteries and to the gap junctions of the arteries and become inflamed, and then we get the type of plaque that could break off, or almost like a pimple and cause a heart attack or a stroke. From my understanding, it's the wheat and the grains, the amylopectin from the wheat and the grains, and sugar that makes those small dangerous particles. And they could last in the bloodstream 5 to 7 days, where the big particles, the large particles, will last, maybe 24 hours and not get caught up and go back to the liver, and not get caught up into the endothelium of the blood vessels. So if you could talk about why those small particle lipoproteins are so dangerous, and why they could get inflamed, and why that's such an important test, because they're lasting in the body for 5 to 7 days, and they can get caught and get inflamed.
So one of the things I want to mention is that, as you said, diet and taking in a pro-inflammatory diet makes these things worse. But there's also a fairly large genetic component here, and there are, you can look at the panels with some people who really, they're overweight and they're not living the healthiest lifestyle, but their numbers look terrific. And these are people who just won the genetic lottery. They just got lucky. They have no heart disease in their families, and family history is important too. And if somebody doesn't have a history of premature heart disease, and that's important, it's the premature part. Almost everybody has a relative who died of a heart attack or has had heart disease. But if you had a grandfather who had a heart attack at 89 years old, that's not really a risk factor. But if you had a relative who had a heart attack in their 40s or 50s, that's something to consider, and that's a risk factor. And you'll see the people who had that type of a history, even if they live a healthy lifestyle, their numbers might look lousy because of the genetic factor. But what happens is with these lipoproteins is the smaller ones, it often starts with inflammation. So if you think of the tiny blood vessels that bring blood to the heart muscle itself, so the coronary arteries that actually supply this, so heart's a muscle, right? And it needs its own blood supply. And that's the coronary arteries. And these are fairly narrow blood vessels. If you saw them in real life, I mean, they're fairly narrow. And inflammation can start to develop along the walls, the endothelium, right? And that inflammation is think of like a rough, if you rub sandpaper on a smooth surface and you roughed it up. So the inflammation sort of roughs up the surface of the blood vessel, allowing these particles to sort of adhere and start to form a plaque. And it's these smaller particles, because of their size, and they can, as you mentioned, they can get into the junction between these cells. They can kind of, worm their way into these spaces and adhere to the inflammation, and it starts to form a plaque, a clog, essentially. Cardiology is plumbing, and it starts to form a clog. And now this clog can either become a complete clog, which cuts off the blood supply to that part of the heart muscle that blood vessel supplied, or it can break off and go someplace else and either cause a heart attack someplace else or cause something like a stroke, depending on wherever that thing goes. So focusing on reducing the amounts of those particles, and also reducing the inflammation by eating a better diet, by living a healthier lifestyle, that's how you avoid these things.
So say we have a patient who does pretty much everything good, but they have small particles. Should they at that point go on a statin, or is there something better?
Yeah, well, the news on statins these days is hot and cold. There's sort of a mixed bag right now. Statins have been around for decades. There's a lot of good data on statins. We know that people who've already had a heart attack have a better outcome if they take a statin after they have a heart attack. Cardiologists years ago, up until fairly recently, and some still do, they'll say, "Oh, they should put this in the water. They should put Lipitor in the." I do not agree with that. I do not agree with taking any drug that you don't need. I'm not one of those people.
Like fluoride.
Yeah, exactly. Like fluoride, exactly. So I'm not an advocate for that. But statins, I do think have a use. I think they are useful drugs in certain settings. So if you have that person who has lousy genetic cards and has done everything they can to reduce those risks, but their numbers are still lousy, then I think a statin is a good choice for those. There are some newer things coming out to lower cholesterol. They're very expensive. They're injectable as opposed to pills. And you have to have the right patient for that too. But yeah, statins are still a good choice for the right patient, not for everybody, but for the right patient. Then yes, that's something that they can do. Another test that I'd like to kind of put together a picture of somebody's cardiovascular risk is something called the coronary calcium score. So this is essentially a CAT scan. It's basically a limited CT of just your heart. And what it does is look for calcifications or buildup of calcium in the walls of the coronary arteries. The calcifications are a sign of plaque formation, that a potential plaque formation. So if you think of hardening of the arteries, that's when one of these plaques has been there for a while. Calcium starts to work into the plaque and sort of make it visible on the CAT scan. So when you do a test like this, which is it's minimal radiation, it's inexpensive. By the way, you're going to pay out of pocket for this test. Medicare and the insurance companies,
right? Like $99.
it's about 200. It's about $200 depending on where you 150, $200. It's not ridiculous. It's dinner out. It's not but you get really good information from this. So what you get as a result is a number, a score. The best score is 0. You want a 0 score. That means you have no calcifications. Higher the score, higher your risk. So you'll get a raw score. Then you'll get 4 individual scores for the 4 great vessels of the heart. So you might have somebody who has, let's say, a total score of 100, and 90 of those points are in one vessel. The other 3 are either 0 or single digits, and all of that number, and more commonly, it's the LAD, which they call the widowmaker. So you would even know to tell a cardiologist, hey, listen, I think he's got something brewing in this particular vessel. Then you get a percentile rank based on the age, gender, and ethnicity of the person, because most people 50 and above are going to have some degree of calcification. Very few 60-year-olds have a score of 0. But if you have a low score, you may still be low risk because they'll compare you to other people of, again, your age, gender, and ethnicity to say, you know what, you're about average for your age, and I don't consider you at higher risk. But this is a nice test to go along with these. There's no single one test other than doing an angiogram and doing catheterization, which is expensive, invasive, and you can't do for everybody, to say, what's this person's risk of having a heart attack? So combining these blood tests that we've been talking about and an imaging study like the calcium score, you can get a pretty darn good picture of their overall risk, so you can help them to mitigate those risks.
My understanding is, and correct me, is that the calcium score pretty much increases about 25% per year. What can we do to slow it down? And is there any way to reverse it? I heard some studies on vitamin D, possibly with K2 reversing it, omega-3s, keeping it, kind of keeping it in check. Licorice root actually being helpful, garlic, niacin. Any of these things that you recommend?
I would say, I would say it really just maintaining the healthiest, balanced diet that you can. I'm not a huge supplement person. I don't take a lot of supplements. In the winter, even here in Florida, I take vitamin D because even here in Florida, it's tough to get enough sunlight and to get enough vitamin D. I don't think there's enough data for any one ingredient to say, hey, everybody should be doing this many milligrams of this supplement to prevent this. I really think it's an overall thing, because there's always the supplement of the month, right? It was resveratrol, then it was it's always something else than the next big thing. I'm going to take now it's turmeric, right? But I think turmeric is great, but none of these things is a cure-all. None of these things is the answer to every problem. The way to approach these things, and it goes back to the foundation we've been talking about this whole time, is a well-balanced, healthy, well-portioned diet and staying active and doing these things. So I don't think there's any one particular ingredient. Vitamin D, well, let's talk about that for a second. In recent years, we found out how important vitamin D was. When I was doing my training and going through medical school and residency, vitamin D, the only thing you talked about it was with bone health. Vitamin D's main job, and that we traditionally have talked about it, is to help your body absorb calcium from the food that you take in. So if you're vitamin D deficient, we tell people your bones can't really be healthy because you can't absorb calcium from the food that you take in and from your diet. So you need the vitamin D to have the calcium. But vitamin D is so much more important than that. It's actually classified as a hormone. And there's so many other functions, particularly to immune health, that we're finding how important vitamin D is. If you look at even going back to COVID, one of the greatest risk factors for people dying of COVID, it wasn't age. People always the old people. It was vitamin D deficiency. A lot of people think that people who died from COVID, it was vitamin D deficiency because their immune system was poor and couldn't function properly to fight off which was a fairly mild virus. So vitamin D is really important, and having those levels checked is important as well. A couple of years ago, Medicare and some of the insurance companies started to complain, because I've been ordering vitamin D on everybody for quite some time. And then about 4 or 5 years ago, we were getting notices that, they didn't want to pay for vitamin D anymore unless you had a specific diagnosis code. Everybody should be checking vitamin D at least once a year because so many people are deficient. Now, I see it less in Florida than I did in New York, but I would say 80% of my patients in New York year-round were vitamin D deficient. And when you start to replace it, their overall metabolic and immune health improved tremendously. So vitamin D is a big one.
What do you think is the optimal? What are you looking for? 50 to 80? What's optimal?
I would aim for about 50 to 70, 50 to 80, because don't forget, you can have too much. The fat soluble vitamins, right? A, D, E, and K. You can actually have too much of because our adipose tissues, our fat cells, because these are fat soluble vitamins. If you take too much, they get stored in these tissues that can actually become toxic. Unlike the water soluble vitamins, like the B vitamins, like you can't really overdose on B12, right? You can't overdose on vitamin C. You'll just pee them out. If you might get a kidney stone from too much vitamin C, but you're not going to overdose on them. They're not going to become toxic. Whereas something you can take too much D. So you got to take really a lot of it though to become toxic. So the standard of what is considered to be deficient is about 30. But I think even that's not quite enough. I think the 50 to 80 range, as you mentioned, I think is probably ideal.
I think it's interesting that vitamin D is an immune modulator, and there's been studies on the flu. If your vitamin D is at a good level, you cut your risk of getting the flu by about 50%. Probably works better than the flu vaccine.
Agreed.
So what are you talking about more labs? What do you think about checking insulin, fasting insulin, and even 2-hour insulin?
I think for most people, it's not necessary. I think for younger, healthier people, I do a hemoglobin A1C on pretty much everybody. If you're not familiar with hemoglobin A1C, it's essentially a 3-month average of your blood sugar. So if you go and have your glucose checked, or the finger stick when you see diabetics check their glucose, that's a snapshot. What is my glucose right now? The A1C is a 90-day look back at how has your blood sugar been over the last 90 days. And it's not really affected by, was I fasting when I came in? Did I have a bowl of ice cream the night before having the blood checked? It's a weighted average. So I do an A1C on everybody. And if their A1C is healthy, I don't really think it's cost effective or really necessary. I'm not getting a lot of useful information on checking things like insulin levels on those people, because 99% they're going to be good. So I think the yield rate is fairly low for that information.
And what do you think is the optimal for A1C?
So it's interesting, 10 years ago, if
Not
you were
optimal
under
for
6,
Americans. What's optimal?
Yeah, no, you're right. So these things are ever evolving, and they keep moving the goalposts. So 10 years ago, if you were under 6 and under was considered normal for hemoglobin A1C, which roughly equates to maybe 130 as an average overall. Now it's 5.6 to 5.8. 5.7 is considered normal. I think if you're in the low 5s, I think you're doing great. I see very few people that get under 5. You have to kind of starve yourself to get under 5, and I don't think that's really necessary. I think low 5s is a good target.
I saw, like you say, it's almost impossible. But I saw a study where if you have an A1C the difference between 5 and 6, there's like a 3 times greater risk of having a heart attack.
Yeah, yeah. It's very difficult to get it to past a certain point, and I don't know. Like life's a balance, right? We try our best to maximize the healthy things and to minimize the unhealthy things, right? But we also want to enjoy our lives. So I think one of the hardest things to find is where is that balance, right? Because I want to be able to go out to dinner. We work hard, right? I want to be able to go out on a Saturday night, and I don't want to think about what I order at the restaurant. And I usually don't. Like, I don't go to a restaurant. I go out with my wife or with some friends. I really shouldn't have that. I really shouldn't have that. I'm good most of the time. So if I go to a restaurant and I want to have something, the hell with it, I'm having. I'll have a dessert. The trick is to keep that balance where that's not all the time. So once a week, and you never call it a cheat, it's a treat, because a cheat implies guilt. So if I'm good most of the time, I'm not going to feel guilty about indulging myself here and there. And it's just it's really a semantical thing, right? It's semantics. It's a word. But to say, oh, it's my cheat. No, it's not a cheat. It's a treat. A cheat means I should feel guilty about it, and I don't. But finding that balance where you're still enjoying your life, you can go on vacation and maybe eat or drink a little bit more than you normally would, as long as you come back and go right back into your regimen, then you're never really too far off. So getting back to these numbers, where how low can I push my A1C? Well, I don't know, how low do I want to push it? How restrictive do I want to be, and to what benefit, right? What benefit am I going to get out of being over restricted? And I think there's a point where going extreme is more effort for less results and less benefit. I think the rate of return decreases when you get to those extremes.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
What do you think? So many integrative guys are now using a DEXA scan to body composition. What do you feel about that? And do you feel it's helpful?
I haven't really incorporated that into my practice. I've been looking at some of these studies. I'm open-minded to it. I haven't seen enough data to make it change my practice methods yet, where I'm incorporating that. But it's an inexpensive test. Yeah, it's a little bit of radiation. I would be willing to consider that as more and more data comes out. I think it's an interesting approach. But you could probably get the same kind of information in some of these other modalities that we've been talking about.
I mean, I guess you could measure the belly and look for the metabolic syndrome.
Well, I do a percent body fat. We use an impedance scale. So every wellness visit, one of the screeners that we do is a percent body fat. Now, those machines aren't the most accurate, but it gives you a good idea. Now, if someone's got a very high percent body fat, then that's something we can focus on. So I think that's a fairly useful tool as well.
We talked about fractionating the cholesterol. Tell me about triglycerides. How important is that test?
Well, it is important. But one thing to remember is that's one of the sort of labile things that can change based on whether did you come in fasting or not. The idea of coming in fasting for your bloods is something that we're like, I can't eat, I got to have blood drawn. It really doesn't make that much of a difference for most of the blood tests. Like I said, the A1C isn't affected by that at all. It does affect the triglycerides. And it's just another piece of the puzzle, right? Because it's just another form of how these metabolites circulate in your body. So you can have somebody who has a healthy overall cholesterol or a healthy ratio comparing the good and the bad, but their triglycerides might be high. And a lot of times that's a function of their diet. That's one of the things that you can attack straight away. That's less genetic, and it's more what they're putting into their bodies. I think it's important because it points to the overall health of the person and their lifestyle. It's just another indicator. And it's something that you can work on very quickly to reduce triglycerides just by reducing, their intake of certain foods.
I've had a number of patients that had a vein occlusion in their eye, which is a stroke in the eye.
Yeah.
And in the old days, I used to send them out and they would come back and they would never find anything wrong. So I went to the Institute of Functional Medicine. I took the vascular biology seminar by Mark Houston. You probably know who that is. And, he's a very famous integrative cardiologist. And one of the tests that they recommended to do was LP little a. And I've had 3 patients who had a vein occlusion, young patients, and that's what was positive, LP little a. If you could talk a little bit about that to our audience.
So this is another test that it's not part of my standard panel when I do the yearlies, but it's kind of gaining some momentum as an indicator, like you mentioned, that we're trying to find early warning indicators, right? When you can look at somebody's overall picture, and that's another one that's gaining momentum. And there are other ones that have kind of fallen by the wayside that I think 10, 20 years ago we were checking, or like vitamin E, right? Everybody was in the 80s and 90s, everybody was taking vitamin E. And then it came out and said, no, that's not necessarily a good thing. It might even be harmful. So we have to constantly evolve. Lipoprotein A, yeah, I haven't really incorporated it much yet, but that's another thing that I'm looking at, and I'm certainly open-minded to.
And how about uric acid?
Yes, I am using uric acid. Now, traditionally, uric acid has been a marker for gout, right? People who get gout, gout is a crystallization of uric acid into joint spaces. And if you looked at uric acid crystals under the microscope, they look like tiny needles that cause great pain and inflammation in the joint spaces. But uric acid has also been shown to be a cardiac marker. That is one of the things that I do use. That's actually part of this Cleveland Heart Lab panel. There's good data on uric acid as a marker. Yeah.
And do you think elevated uric acid is mostly genetic or mostly related to too much fructose and sugar?
Yeah, it's really both. It's really both. There are people who eat a very clean diet and they're really doing all the right things, but they get tons of gout and they have high levels of uric acid because they lack an enzyme to help break it down. But other people, it's just that look, and they drink too much alcohol, they eat too much, high protein foods, they eat too much seafood, shellfish, and things like that. So it's a mixed bag, and that's the genetics are really important because you never know what percentage is genetic and what percentage is lifestyle, because it's different for everybody in every type of situation. That's why medicine is never a cookbook. You have to figure out the right plan for each person.
And do you think being on long-term colchicine or allopurinol is dangerous?
If you have very high levels of uric acid, look, everything it's always a risk and a benefit, right? And nothing is ever zero risk. So now colchicine's been around for a long time. Allopurinol's been around for a long time. I have people who've been taking both of these medications for decades. They are generally considered safe and effective. So is it dangerous to be on these drugs? I'd say no, but are there people who end up with problems with their kidneys or things like that? Sometimes they do. You have to be careful with allopurinol too, at least when it goes with gout. If somebody is in the midst of a gout flare-up or is very prone to get frequent flare-ups, you can give them allopurinol and make it worse. So you have to be a little bit judicious with use too. But no, in general, I would say that it's not dangerous to be taking these drugs, but you'll only take it if you need it. I would never do these things preventatively. I would never do these things prophylactically in a patient.
And have you ever considered maybe doing a nutrition panel, like a Genova nutrition panel, where you're looking at all the different vitamins in people's body? And do you think that could be helpful? And to say, well, all these different markers are low, all these different vitamins are low, your B vitamins are very low, and your C is very low. And, we got to adjust your diet a little bit based on doing like a Genova nutrition evaluation.
I think it could be useful. It might be a little bit information overkill for most people. I think, I have, at least in my practice, I have a fairly affluent, educated patient population, and they're mostly eating pretty healthy. Now, they might be overeating or they might be overindulging, but they're eating a fairly good variety of foods. And if you eat a fairly decent variety, you're really not going to be deficient in most of these nutrients. If you eat your fruits and vegetables, if you eat legumes, and if you kind of really spread it out and balance it out, it's very unlikely you're going to be deficient in most of these things. So again, there's a little bit of cost effectiveness here too, where you could take everybody and do all of these tests and money wasn't an object. Sure. So I think from my practice, it would be a low yield kind of a thing, because most of my patients are eating pretty well. They're buying the better quality foods. They're not eating the high processed foods. They're eating better than probably the general population of the country. So I don't know how useful that would be in my practice.
And people that are on statins, it could affect the mitochondria, be a mitochondrial toxin. Do you recommend for those people CoQ10 or any kind of mitochondrial?
I do. I have most of my, pretty much anybody who I start on a statin, I tell them to start taking CoQ10 with it too. Now, you could talk to people, and people have been talking for years. Oh, I started taking Lipitor and made all my muscles hurt. I got aches and pains all over the place. Most people who had statin-induced myalgia or muscle pain from statins, most people, if you replace their CoQ10, that gets better, and then they can tolerate the statin. So yeah, I think that's a very good tool.
So anybody you put on a statin, will you automatically recommend CoQ10, or do you wait for them to get a myalgia?
No, I advise people to start CoQ10. Not everybody does it, because it's another thing to take to remember. But I do advise people that they should.
And I assume that you probably see a lot of patients on statins over the years, when you were in New York and here. What percentage would you say do get, forget about this, what the studies say, what percentage do you think in real life do actually get myalgia? And what percentage would you say they get a very serious myalgia?
I would probably say 25% will get some kind of a myalgia. A serious one, maybe 5%. And again, the majority of those people, if they take the CoQ10, they will tolerate it better. I find that actually generic Crestor is better tolerated than Lipitor. So Lipitor is atorvastatin, Crestor is rosuvastatin. If I have somebody who's intolerant to one statin, I will often switch them to rosuvastatin, which is Crestor, which I find to be better tolerated than some of the older statins, with or without the CoQ10.
And I don't know if you have many patients. You talked about the injectable, the Repatha, to lower cholesterol.
Yeah.
You see many side effects to that, and what would they be?
I probably have a handful of patients on Repatha. It's extremely expensive. It's tough to get approved. It's like $1,200 a shot. So right now, I probably only have 3 or 4 people. I'd say in the last 10 years or 5 years since it's been out, maybe 10 people total. It's been pretty well tolerated, other than, injection site irritation. It's been pretty well tolerated. I haven't had to stop it on anybody because of side effects. So they're pretty well tolerated.
Now, we look at the hallmarks of aging, and you mentioned this before, insulin resistance. You could kind of explain it before, but tell us how to prevent insulin resistance and why insulin resistance is so dangerous as people get older, and what it does. It increases your risk of stroke and cardiovascular disease, et cetera, et cetera. And most Americans are insulin resistant. I've seen studies as high as 92%.
Yeah.
Are we insulin resistant? What can we do to prevent it?
So let's talk about insulin resistance basically as a spectrum. So it's basically the spectrum of diabetes. You can have, and diabetes isn't a yes or a no thing. It occurs on a spectrum. So you can have very mild diabetes or very severe diabetes, poorly controlled. So let's call insulin resistance very mild diabetes, because that's essentially what it is. Why is diabetes, whether it's mild or severe, why is it dangerous, right? So as we mentioned before, insulin isn't working as well. So again, that's type 2. Type 1 is called juvenile. It's just, you're not making enough insulin. The pancreas was damaged, so it's not making enough insulin. You have to just take the shots and replace it. Type 2, which is by far the more common, this is the overweight middle-aged people who develop diabetes. This is type 2 diabetes. So the sugar level, the glucose level is remaining elevated in the blood. So why is that bad? Why is that dangerous, metabolically speaking? Well, sugar molecules are very large. So if you look at a molecule, the smallest molecule is water, right? H2O, 3 atoms. Glucose is C6H12O6. So 6 carbons, 12 hydrogens, 6 oxygens. So you have 3 atoms, or you have, what is that, 18? So sugars in general are very big molecules. Well, big things clog small places. So if you look at the places that are damaged by poorly controlled diabetes, you see it in the retina. So the retinal arteries and the retinal vasculature, because they're the smallest blood vessels in the body, and they easily become clogged with these larger molecules and the inflammation that they cause. But increased risk for heart disease because of the vessels there, kidney damage because the kidneys are very vascular with very small blood vessels. So all of these places can become damaged over time by poorly controlled blood sugar. So whether it's mild insulin resistance or mild diabetes or the more severe forms, over time, you're running the risk of heart disease, stroke, heart attacks, and all of these problems because of damage to the vasculature.
And would you recommend a low carb diet at this point?
Yes, everybody should be on a low carb diet. I mean, we eat too many carbohydrates. And as we mentioned before, that was the FDA screwing everybody over by trying to push a low fat diet. Remember Snackwells?
Yes.
Snackwells, the low fat cookie. Well, I can eat as many Snackwells as I want because there's no fat, right? Well, they're loaded with sugar and carbohydrates. So all of those low fat snack foods that in the 80s and 90s, I remember the commercials for, heart healthy, low fat, were terrible foods. They're terrible things to put into people's bodies. And then by fooling them and making them think that this was a healthier alternative, it's just criminal. We're still dealing with the repercussions of the deception of the government and the food industry going back decades.
We talk about insulin resistance, and you brought up inflammation. One of the things insulin resistance causes is inflammation being the core component of chronic disease. Talk to us about inflammation and how we lower inflammation, I guess similar as we would with insulin resistance.
Sure. So again, inflammation, really in the last maybe 5 years, I think we're realizing how central and how pivotal controlling inflammation is. So it goes back to the central tenets, right? It's looking at your food, eating a lower inflammation diet. Actually, this is where turmeric and curcumin comes in too. It's a natural anti-inflammatory, it can help bring down inflammation levels. But really just living that clean, healthy lifestyle is the best advice, because you can look at all of these different things. I remember when Dr. Oz was popular, and he was terrific on television. But if you did all of the things that he suggested that you do, you'd be taking like 100 supplements a day. Wow, today's study is on this supplement. Okay, well, Dr. Oz says I should take this. Okay, great. And tomorrow he's going to talk about this. I should take that too. If you did all of these things, you'd be taking 100 different herbals and supplements and things like that. You'd be on 5 different diets. It's very difficult. You can't even keep track of it. God made it really simple for us. He gave us these whole foods where if you eat certain of these things, I'll give you an example. Quinoa, right? That's the quinoa. It looks like quinoa, Quinoa. It's a grain, right? It was a staple grain of the Incan Empire. It's become popular in the health food circles and people trying to, as sort of a rice or pasta alternative. And it looks like couscous, but it's actually a grain, and it's grown in South America. It's enormously healthy because it's nutritionally dense, right? So this one grain has an essential amino acid. You guys, what an amino acid is, the building block of a protein. So every protein is made up of components called amino acids, and there's a bunch of like 22 of these things. And our bodies are programmed. We have the DNA blueprints to make most of these amino acids so that we can synthesize proteins for ourselves. Well, there's 6 of them that we can't make ourselves. We have to get them from our diet. You have to take these things in the food that you eat. Quinoa is one of the only foods on the planet that has all 6 of the essential amino acids in one food, and it's loaded with protein. So yeah, it's a grain, and there's carbohydrate associated with it, but what do you get for that carbohydrate? You get a lot of protein, and it's called the complete protein, because it has all of these essential amino acids that you can't make on your own. So to go make a choice like that over something like rice, which has probably a similar amount of carbohydrate, which gets converted into sugar, but you don't get the protein and you don't get the other nutritional value that goes along with it. So you have to choose foods that are nutritionally dense and that you're getting something for it. So like you mentioned Greek yogurt. Greek yogurt has fat. Yeah, it does. But it also has protein, which helps balance out the fat. So rather than go with a non-fat yogurt, I will not eat non-fat yogurt because it's loaded with artificial sweeteners. I'd rather have the fat because that's less harmful than the chemical in that artificial sweetener. So that's where educating people, and then people don't know. So, I got to eat the low-fat yogurt, right? I mean, isn't that better for you? We need to make an effort to educate people on nutrition. Even as a doctor, I taught myself more nutrition than I learned in medical school. Medical school, there was a 1 semester, like 1 hour a week nutrition course. Yeah, you learn the basics, but all the stuff that we've been talking about nutritionally, now I've taught myself in the subsequent years. We need to train doctors better. We need to train schools better, and kids to start at a young age to start to eat healthier. And I have a hard time too. I have teenage girls, and my younger daughter is 12 years old. And what does she want to eat? Chicken nuggets and French fries. And we have to force feed the vegetables, but we keep trying. And eventually she's going to learn to eat the things and we model the better behavior. She sees what I eat. And eventually she's going to start to eat like that too. Like my older one has now started to eat better because she sees what we eat. So you just have to start younger, and we need education on the way to do, because these things, again, they're not hard. It's not complicated. We've just done such a poor job of it and it's intentional. It's the food industry. It's the pharmaceutical industry. Listen, Novo Nordisk is making billions of dollars on Ozempic. They don't want you to be healthy. They want to sell Ozempic. So it's in their interest. The model is all wrong. The pharmaceutical industry and the food industry is set up to make us unhealthy because they make more money that way. So we have to take it into our own hands and take control of our own health.
Let's talk about the microbiome, as we talk about the hallmarks of aging and abnormal microbiome. How much do you think about the microbiome, and how important would you say it is?
I do think it's important. So we're talking about the bacteria, the natural sort of flora of our mostly the gastrointestinal system. So I think people don't realize how important the microorganisms that live in our gut are. Eating something like yogurt is really good because you're constantly replacing those bacteria and keeping those populations healthy. I do advocate for most people, if they're not eating a lot of yogurt, to take a probiotic. I think that can really help to replace some of the bad bacteria with good bacteria. I also, if I have to give somebody an antibiotic, I often will tell them to take a probiotic to prevent diarrhea that goes along with antibiotics, or something like Clostridium difficile, C. diff, from using antibiotics too much. So it is important. It's also important for our immune systems. By having these huge populations, and we're talking billions and billions of bacteria that live in our gastrointestinal tract, think of it's like a sparring partner for our immune system. So these are bacteria that that populate our bodies, and they're supposed to. They make us actually healthier because the immune system is keeping them in check. It's like a boxer who has a sparring partner. The sparring partner isn't there to hurt the boxer. It's there to make the boxer stronger. So these bacteria do that for our immune system. By the presence of having these good bacteria, which aren't there to make us sick, but they're also foreign bacteria. So the immune system is constantly sort of sparring with these bacteria, and it keeps us healthier overall. It keeps our immune system stronger.
And how about the hygiene hypothesis, where the mothers don't let the kids go out and play in the dirt, and they're wiping their hands all day long with antibacterial wipes? Yeah,
I think we overdo it. Listen, nobody likes to be clean more than me. I picked an industry where I didn't have to go get dirty every day, right? I picked a very clean job. I wash my hands probably more than anybody else in a day, but I'm seeing patient to patient. I do think we overdo the cleanliness. And I think our immune systems can suffer because of that. Look at a kindergarten teacher or physicians, right? Typically, elementary school teachers and doctors get sick a whole lot less than the general population. Why? Because we're constantly exposed to these pathogens, to bacteria and viruses that can make us sick. So after a while, your immune system has seen all these things over and over again, and you don't get as sick. They did a study years ago that showed that kids who had pets had far less asthma than kids who didn't, because their immune systems were exposed to these allergens like pet dander and things like that, so that they were more resistant when they had a new exposure. So if you think about when we were kids, right? We didn't have kids with peanut. You had a bake sale. We didn't worry about that there was nuts in the browns. We didn't have all of these problems with kids with asthma. Maybe there was the one kid with asthma that the lunch lady had to hold their inhaler while he played kickball. But now we see food allergies on the rise. We see asthma on the rise in children. And I think part of that is the over cleanliness. And again, I'm not saying that we shouldn't be clean and keep our hands clean. Never touch your face unless you just wash your hands. So I'm not advocating for filth and dirtiness. But I think we do overdo the typical exposure of a kid playing in the dirt and making mud pies. They should be outside playing in the dirt. I think there is something healthy to go along with that.
For the microbiome, fermented vegetables. What do you think about fermented vegetables?
Yeah, you look at like kombucha and these fermented products. I think they're great. I don't know that they're something that you have to do, but if you enjoy these things, I think it's great. Kimchi and things like that. I think if you like those things, more power to you. You should incorporate them. I like stuff like that. But again, coming up with the do's and don'ts of how to live a healthy lifestyle, because it's so complicated. Look, we just spent an hour talking about all the things you could possibly do. There is no one formula to good health. It's trying to incorporate as many of these things as you can that fit into your lifestyle. And I think that's where having a good relationship with your doctor who has the time to sit down with you. And that's why a model like my current practice is so good, because I have the time to sit, I have to spend an hour with people when they come in for their yearly. It's a full hour. And we can get into these details where, it's like 10 minutes if you're lucky. So having a doctor who cares and who has the time to spend with you is very important. It's harder and harder to find. That's why this membership-based practice, it's an expense, but I think it's actually really worth it. I think you get a lot of value for your money.
I have a good friend in New Jersey, Dr. Joe DeRosa. I don't know if you know him. He is MD VIP. And
I do know that name. I don't know him personally, but I do know that name.
He's a very good guy. We played softball together. As we move on, the hallmarks of aging, oxidative stress, the imbalance between free radicals and antioxidants, rusting as we get older. If you could talk about that concept.
Well, here, that kind of ties into what we were talking about with the seed oils. One of the things that they're finding now is that these seed oils, as we said, have been incorporated into our food supply more and more in recent decades, causes more oxidative stress. People hear about omega-3s, the omega-3 fatty acids. Well, something also called omega-6 fatty acids, and this comes from linoleic acid that's in a lot of these seed oils. Well, the omega-6 promotes oxidative stress and oxidative damage. So this is sort of, if we use an analogy of a computer hard drive, right? So think of that as your DNA, as your genetic health, right? So you can degrade over time that memory. So oxidative stress is damage to DNA. Now we have mechanisms in place to repair that damage, but this oxidative stress can damage our ability to repair ourselves. So we have to really look at a lot of that stuff too. And we're really just getting to the tip of the iceberg on how important these oxidative stresses are. Why antioxidants can help protect us from these things. So that's where you look at like leafy greens and the vegetables that have a lot of antioxidants in them can counteract these exposures that we really can't control. To a certain degree we can, but listen, we're all going to have certain degrees of radiation exposure. We're all going to get some of these chemicals into our bodies, even no matter how clean and healthy we choose to eat. got to eat in restaurants sometimes, right? We want to go out to dinner. We don't know what they're putting in our food. So having diets that are high in antioxidants and these healthier foods actually helps to counteract some of the bad things that we're coming into contact with.
One of the things I see with my patients is they eat the same 4 or 5 foods over and over again. Their food isn't diverse enough. Their diet.
That's because they're not Italian. If you're Italian, you have to teach them how to eat like a. No, you do see that, and particularly in older people who live alone, they don't like to cook or they're not good cooks. So they either eat, TV dinners, or they buy prepared foods over and over again. And I really only eat meat potatoes. I really don't. And that's no good, because the variety is what keeps us healthy. It's how we get that balance of nutrients that we all need.
And this is kind of more maybe futuristic, but stem cells, stem cell exhaustion. What do you think about that as we're going forward in medicine?
I think stem cells are going to play a big part in medicine going forward. Right now, it's sort of on the cutting edge. It's very expensive. So again, I have an affluent population here who, instead of going to get a knee replacement, they'll spend the 15 grand and go to Costa Rica and have a stem cell injection. And I'll be honest with you, I've seen really good results. That are many people who can avoid something like a knee replacement or a hip replacement surgery. People with the ever-present back pain as people age, right? The spinal stenosis, the degeneration in the spine. The stem cells, can make a big difference.
Interesting. How about autophagy? Cleaning out the dirty cells, the bad cells. Something that people are starting to think about now in functional medicine, integrative medicine. Something that you think about. Do you think it's important?
I think that's a little farther off. I can see the stem cells coming into play on a wider basis sooner than something like the autophagy. I think we're at the it's very nascent right now. I think we're at the early stages of that. I think it's interesting to look at going forward. But I see the stem cells right now as probably more likely to be. The price is going to come down, because right now the limiting factor is the price, and it's very expensive. It's $10,000 to $15,000 for something like this, and most people don't have that just sitting around where they could go drop that.
As we finish up, I'm going to ask you about some a little bit more esoteric things. The concept of hormesis. Putting stress on the body to make it stronger, whether it's a cold bath or infrared sauna. People that go to the gym, that's hormesis. We're stressing the body to make the body stronger. Sure. What do you think about the concept of infrared sauna? Although if you live in Florida, you're in an infrared sauna.
That's right.
Or cold baths.
Yeah, I'm very reluctant to jump into the latest fad of the day. Unless I see a lot of evidence on it, or if I try it myself, like the cold bath thing. I see this all the time. I don't want to go sit in an ice cold bath. I don't want to do that. It might be good for me. I don't know, but that's unpleasant. And I'm at the stage of my life where I'm trying to minimize unpleasantness and pain and maximize good things and pleasure. So maybe it's really good for you. And I understand the concepts of reducing inflammation and the cold and the metabolic benefits of it. And if somebody wants to go sit in a cold bath, I'm not going to discourage them and tell them that they shouldn't. But it's really not something that I'm excited about doing. You always have to be a little careful with the latest fad. I think the one thing that never goes out of style is common sense, healthy living. And this goes back to this. The whole foods and exercise. I'm a big fan of exercise for sure. And again, that's a form of stressing the body, and we tear down old muscle to make new. But I think you have to be cautious on the fad of the day, and let it play out. And if it makes sense, you can try it. If it doesn't make sense, then don't. So I think we have to be. I don't want to go sit in ice water. I just don't.
I want to thank Dr. Contacessa for joining me today. Is there anything I didn't ask you about that you might want to share?
I think we covered a lot of really good topics today, and these are things that I'm passionate about. Diet and exercise, and one thing, another sort of phrase I use all the time when people are trying to live a healthy lifestyle and lose weight, and they they focus too much on exercise and not enough on the diet, and they say, "Oh, I'm working out more." Well, that's good. I like that, but you don't lose weight in the gym. You lose weight in the kitchen. So that's just one other idea that I want people to understand. That let's say you go and you do a spin class at the gym. That's what you like to do, right? 45 minutes in the gym, you sweat. You had a great workout. Maybe you burn 300 calories, 400 calories tops. That's a cookie and a half. It's a glass and a half of wine. So to think that you're going to lose weight from doing more in the gym, you're not. I do advocate for exercise, but not as a weight loss tool. So I think that's one other thing we didn't mention as far as lifestyle that I think is important for people to know. Exercise is important, but that's not how you lose weight.
Well, now that you bring that up, I see the same people in the gym for 5 to 10 years and they never lose any weight.
That's right.
There every day.
That's right. That's right.
Dr. Contacessa, if someone wants to get in touch with you, become a patient of yours, how could they do that?
So I'm in Palm Beach Gardens, Florida, and I'll give my phone number. It's 561-622-7606. If you live in the area, we usually set up a meet and greet first. You come in and sit and talk to me because it has to go both ways. You got to like me, but I got to like you too. If I want to work with people who are going to follow my advice, and it's a partnership. It's an important partnership, and I think that when you start with a new doctor or any doctor, it's not a dictatorial relationship. You do what I tell you to do because I tell you to do it. I take pleasure and I take the time to explain to people why I'm recommending what I'm recommending, my thought process on doing it, what I expect to happen, what could potentially happen, good and bad. And I think taking the time to explain these things, because not all outcomes are good. You could do everything right. You can make every right decision, but sometimes the outcome is bad. But when you tell people what you're doing, why you're doing it, and the chances of what can happen, then they're less likely to be upset with you when things go south. So that partnership, having the relationship where you can have a conversation and have that interplay back and forth, ask me questions. I love it. I love answering questions. And I love making people try to understand complex concepts when I can try to break them down into simple terms. That's why I use a lot of these analogies and things like that, because this is complicated stuff. This is biochemistry, it's physiology, it's biochemistry. And people need to understand these things, at least on a basic level. So I love being able to do that. And I love sitting down with people and working as a partnership.
Please repeat your phone number one more time. I'm sorry.
It's 561-622-7606. You can also just Google my name and you'll find some of the funny videos that pop up, but you'll find my practice information there too. It's called Custom Care Medical is the name of my practice. We are an affiliate of MDVIP. It's sort of like a franchise, but I'm called Custom Care Medical.
Dr. Frank Contacessa, thank you for joining me today. My son just walked in the room and he's the biggest fan of Impractical Jokers. Brady, come over here. Dr. Contacessa has been on Impractical Jokers. Say hi to Dr. Contacessa.
How are you?
Good.
I'm the one who gave Murr the prostate exam, if you remember.
Oh,
Well, Dr. Contacessa, thank you for joining me today. And until next week, this is Dr. Kerry Gelb.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit OIEBroadcasting.com and sign up today.